All right, thanks everybody for coming out. As always, this is Dr. Chris, and I'm back with another podcast. Today I have an amazing guest, Raymond St. Augustine, who is a chiropractor from the Great White North. We got to keep it real here in Canada. And so today we're going to talk to him, and we're going to kind of figure out what's going on in the chiropractic world, MSK therapy world, and see how we can move forward and hopefully work together in the future. So, Raymond, thank you very much for joining us.
Thanks for having me.
Not a problem, brother. First of all, let's get right to it, man. Tell me, who is Raymond St. Augustine, and what is it that you do?
I'm a chiropractor out of Calgary, Alberta, Canada, for those of you who don't know what the Great White North is. And I'm clinical director here at Dynamic YYC Movement Lab. We are basically a clinic setting that's trying to change the way rehab is approached, and the incorporation of manual therapy with such. I basically day-to-day see a lot of patients. I help teach some of our newer therapists that come on board, along with our massage director, Blair Williams, and the founder, Colby Leong. So, yeah.
All right, giddy up. So let's get right to the questions, the tough questions. All right. What is your approach to, this is a two-part question. So what is your approach to rehab? And in particular, what are your thoughts on rehab, active approaches to rehab?
That's a pretty, there's a lot of layers to that question, because rehab can mean like cardiovascular rehab, neuro rehab, MSK rehab, whatever along the sort, but predominantly we focus on MSK stuff, and an active approach required. Like actually for all of those, you need to put in the work in order to get a result. Unfortunately, I always tell this to my patients, if I could rub myself to make my biceps bigger, I would have been winning the Mr. Olympia a long time ago. But it doesn't work that way. You have to put stress to the system adapts, and then we facilitate that.
Excellent.
As practitioners.
Yeah, no, I completely agree. And you know, I often say to people, man, like there is no way around this, right? Like if you have a problem, some work has to be done in order to fix that problem, right? And you either pay for it in the short term by doing the work, active rehab, or you pay for it in the long term when you have chronic pain and you are trying to work to move yourself around and you're stiff and sore and hurt. You always have to pay the piper. Like there's no two ways about it, right? And so the active approach, I agree, I think is essential.
It's pretty funny. One of our weightlifting coaches, he always says, people complain, they're like, "Oh, this is so painful," like, because it's weightlifting. It's just like, it's grueling, it's hard work. He goes, you think this hurts, try not exercising. And then it's a good point. It's like, your body's going to have a very bad relationship with gravity. So
for sure, man. And we are designed to move, right? Yeah. Like that. And we are at optimal health. Like even though I think everybody should lift all the time, let's just put that aside for a second. Just in general, we are designed to move, right? Our bodies are they function at their optimal level when we are moving, right? So people can't avoid it, and they try, but in the end they pay for it, right? So
absolutely,
you have to be moving all the time. Now, you call yourself a movement nerd, okay? And I like that term, but tell us, what is a movement nerd and why do you call yourself that, man?
It was funny because when I first put that up, it was probably 2 years ago. It was with a friend of mine. She was helping me with my social networking thing, like the Instagram stuff. She was like, "Why don't you put specialist?" I'm like, in Canada, you can't actually do that because you need to have specific certifications. It's just like parameters of politics. And honestly, I think if words do really, really matter that much, I think especially for the general population, it requires work just as much as anything else to be able to call yourself a specialist. So I would never call myself that. I think I have a profound passion and a profound fascination with what is included in human movement, whether it's like motor learning or motor control or strength and conditioning or whatever is included in that massive macrocosm. It's I'm not a specialist. I wouldn't be able to call myself that because I'm just fascinated by it. I follow the dopamine in terms of whatever's pulling me towards the next topic that I'm fascinated by, be it running, lifting, the incorporation of both, dance, whatever it might be. It is something I have been obsessed with, and that's more so why I would call myself a nerd more than anything else.
Okay. So what is your, so just as an extension from that, when it comes to movement, what is your background with respect to movement?
Currently, I mostly weightlift. I have a pretty strange movement journey, I guess some people would call it. I was mostly a dancer growing up, hip hop, breakdancing, things like that, all the way into high school. Then I kind of took a divergent. Like you don't really do much when you're in your early years of college, unless you find it early. Um, and then I found yoga. So I was in the yoga for a long period of time. I did my 200-hour in Costa Rica with Marianne Wells School of Yoga. And then I still felt like I was missing something. And then so I started lifting at home. I'm sure a lot of people can attest to this. P90X kind of made it available. And that's where my first introduction to it was, until a friend was like, oh, well, why don't you come to this fitness class? It's not CrossFit, but it's kind of like CrossFit. So then I started going to that, and then it just kind of blew up into this love for lifting, because it was a powerlifting strongman gym. We were doing CrossFit like workouts, and then it just eventually we went into CrossFit, and then it just kind of evolved into what it is today.
Okay.
Mostly weightlifting.
Okay. So, and you, if I'm correct, you spent time in San Francisco, is that correct?
San Jose.
San Jose, okay,
Yeah.
and working on CrossFit when you were there?
Yeah, well, that's where my school was, the Chiro school,
Yep.
Palmer West, and I worked in a CrossFit gym, CrossFit Silicon Valley, for a short period of time. I actually lived in that gym. It was very hard. I would not wish that upon my worst enemy. It's very difficult, but you try to save money in the Bay Area. And then I moved into a more weightlifting fitness, general fitness, strength and conditioning gym called Anchored Strength and Conditioning. Okay. And then I worked with a couple of CrossFit gyms out there too, because that's kind of the hub of where CrossFit kind of was born in NorCal.
Okay. So let's change gears here for a second. As I mentioned before, I've spoken to a lot of chiropractors recently, and one thing that we often talk about is when we start to talk about evidence-based care, we talk about similarities and differences. So how are you and physical therapists different, and how are you and physical therapists the same?
I'll start with the same, because my philosophy is that other than the designation and the ability to bill insurance to one and not the other, there should be very little difference in terms of the interventions of patient care. Like that, it shouldn't look very different. In fact, a lot of patients, they'll email us after our appointment and be like, it's not working. Like I can't bill you under physiotherapy. I was like, well, I'm a chiropractor, so you have to put it under that. And then they're just like, well, that's not what chiropractic is. I'm like, well, that's what my designation is. That's just what I'm allowed to take care under. But otherwise, there should be very little difference, honestly, other than the name at the end of it. But in terms of difference, I think it's probably going to be the education. In physio school, I can only speak to Canadian schools, is they get a larger a broader scope of treatment. So you have to do an MSK, you have to do neuro, you have to do cardiovascular, you have to do post-surgical, whatever the case may be. In chiro school, they typically start you right off the bat running MSK. That's what you do. You move bones, you crack necks and cash checks. That's basically what they want you to learn. So they really put a heavy focus on the psychomotor skills that are involved in it, which is funny because I'm sure you've seen the infographic of comparisons between chiro school and medical school. And it makes me laugh because like a part of like a massive chunk of our curriculum is like psychomotor skills. Like it's like you're you're just learning a skill. You're not learning like you can't put those hours to like a residency. Like it just doesn't make sense. So you're just like, oh, okay, I know what you're trying to do, but like you're taking it out of context, which I think is dishonest to the general public because they'll see that and be like, oh, okay, well, they're the same. And I'm like, it depends. There's different scopes of practice. And like, there's like a whole language that patients in general just don't know.
Mm-hmm.
And I think a lot of these things, they take advantage of that.
Mm-hmm.
So.
I don't, during some of my conversations, it's interesting. I've had people say both ways. What you just said, and it actually tends to be the younger chiropractors who have your similar train of thought, and then the older chiropractors who are kind of the other way. And to me, it's not really a pissing contest. I don't really care, right? I just think like the fallback example that I always have is this. I say, look, you can call yourself whatever you want. A lot of my patients call me Chris. They don't call me doctor. And I don't, unless I say to somebody, if I don't like them, I want to keep a little bit of distance.
Yeah.
And then I introduce myself as Dr. Rayner. Okay.
Yeah.
The rest of the time, Chris, big man, little man, whatever. It doesn't matter what you call me. I don't really care. The example that I always fall back to is this. I said, look, if you're on a plane above the Atlantic Ocean, somebody has a heart attack, right? Like it doesn't matter that I'm an orthopedic surgeon and all I know about the heart is that it pumps ANSEF around the body so that I can do my surgery. It doesn't matter that, right? Like there is some modicum of medical training that I have. Even a psychiatrist, there is some modicum of medical training that they have. So if you're flying above the Atlantic and somebody gets sick on a plane and they say, hey, is there a doctor in the house, right? The PhD doesn't put their hand up. And generally speaking, the chiropractor's not putting their hand up. So like people can talk about the training, but then I go, yeah, but what are you going to do in that situation? Right. And so,
yeah, exactly.
I don't, it's not that I want to denigrate chiropractors or say that their training isn't adequate for what they do. It is adequate, and they put in a lot of work and to achieve what they do, and more kudos to them. I just think it's different. And when people try to say, I had one guy who actually is a chiropractic educator, and he's saying, well, but we're a doctor and we're equivalent. And I'm like, okay, you can say that you're a doctor, but it's different. It's different, man. And you have to know that's different. So anyway, but that's as an aside, but I just think, yeah, I hear what you're saying about that infographic and that whole idea of equivalency, because it's not, and it's not to belittle chiros. It's just, it's not the same. It's different.
I totally agree. So like, yeah, I mean, people have always asked, they're like, well, if you were on a plane and did this, I was like, I have CPR. That's all I can provide. That's all I can provide. And I used to be an RN, right? Like, so I used to be a nurse. So it's kind of like, yeah, I'm going to stay within the constraints of what I'm able to provide as a support. But like, you're not going to see me shoving a pen down someone's throat because they're having an anaphylactic reaction like that. Like, that's not what I'm doing. I'm not going to trach someone, like, oh God.
There you go. So let me ask you then, you were an RN before. So why did you switch lanes and go into chiro, man?
It's actually pretty interesting because when I was in nursing school, I loved it. I really enjoyed it. I loved patient care. I didn't want to be a unit nurse. I didn't want to do that. So I went into urgent care, and I was actually a corrections nurse as well. And I, there was just something about it. I hated shift work. It was awful. I'm surprised you like being on call so much. Like, and it was just like part of that was harder on what I wanted to do. And I was coaching CrossFit as a part-time gig for fun. And then I was noticing that I was enjoying that way more. I was working with our clients at the CrossFit gym that I was working at CrossFit AI. And we worked with chiros, and we would send a lot of our shoulder injuries, like, oh, you should get that looked at, to one of the chiros that I knew that all my, like, the head coach loved. And then our low back people, we would send to a different chiro that our head coach loved. So like I learned to work with them, and I didn't have a huge exposure to physio. But it was interesting because I called my nursing board, the Karna, and I was just like, what does my scope of practice allow me to do? And they said everything. I could pretty much do everything. I could do ultrasound, like therapeutic ultrasound. I could do all that. They were just like listing stuff, except manipulated joint past its paraphysiologic space to the point to which it makes a sound. I'm like, oh, an adjustment? I'm like, that's the only thing that I can't do in comparison to physio and as a nurse. I was like, well, then it makes sense. I'm going to go to a school that provides a much wider scope of practice that allows me to diagnose and treat without someone guiding care, which would be what I would have to do as a nurse, right? So that's kind of why I chose it. But it was, again, these are things that most people just don't know to ask those questions, right? So.
Okay. So let's go back a step. And so, how are you and physical therapists different and the same? We talked about that. Well, and we were just talking a little bit around the outsides of this. How are you and physicians different, and you and physicians the same? And let's narrow this down and say MSK physicians. Okay, so orthopedic surgeons, physiatrists, sports meds, right? So just keep it to the MSK.
So to be just to be frank about what it is, I think generally most sports med stocks that we work with, they just don't have the time that we can provide to our patients. Like we here provide 25 to 45-minute appointments depending on the treatment or what's required. And a big part of the initial or whatever is just talking, getting a history, and then making a decision for both sides. That's basically where we go, where we share like the exact same thing. Then there's another side of scope of practice where like, okay, this person isn't getting better. There is a family history of rheumatoid arthritis or something along those lines. There's some red flags or yellow flags that we as a chiropractor picked up. I'm like, you need to see a sports med. Like, we need to figure this out. It doesn't mean we have to stop care. It means that we need to have an additional path going coincidentally together and then meet them back. So there's a scope of practice difference for sure that I think is a very important thing. And then the same, it's like, I think anyone who does a good initial or a good history taking or a good orthopedic examination will follow what the textbooks, like Chad Cook's book of orthopedic testing is amazing. So like, and those clustering, like there should be very little difference. That's the point of orthopedic tests, is that they're standardized and retested. So if we all follow that, at least we have a framework to work within. Because there are some practitioners that are like, oh, you don't need orthopedic tests. They don't tell you anything, blah, 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 blah. They only tell you that there's pain in that range of motion. It's like, yeah, but it's a language that a group of people have and share, because the way I approach care is going to be different than someone who has a strictly yoga background or a strictly Pilates background, right? So there's that shared and sameness where we can collaborate together for the advocacy of what the patient requires.
And just to touch on the physical exam, the orthopedic tests and stuff, I remember going through my orthopedic training, and hearing multiple times from multiple staff physicians, you do your history and your physical exam, and between your history and you get your differential diagnosis from that, right? But between your history and your physical exam, you should pretty much know what's going on, right? And the special tests, the imaging or any other kind of special test is only there to corroborate what you are already 90% sure of what is going on, right? And I remember one particular preceptor saying to me, man, if you don't know from your history and your physical exam what the problem is, then there's a problem with you, right? Because you should have a pretty clear understanding. And yes, every once in a while there's a weird and wonderful zebra, or something is going to be a little bit more subtle and a little bit harder to ascertain what it is. But it's important that you have the ability to interpret the results of those tests. And as you said, those are standardized tests, right? Like that people have generally accepted. Studies have shown that it gives you this information, right? So you need to have some level of mastery of those things in order to sort of understand what the body is saying to you.
Absolutely.
So as an extension from that then, and you mentioned this a little bit, if you were to think about your ideal relationship or role with an MSK specialist, whether that be an orthopedic surgeon, sports med, or physiatrist, what do you see as your role, or where do you see yourself in the spectrum when you think of that group of people?
That's really tough because like we had a sports med in-house too, and we were trying to figure that out. Like, what are the roles that everyone plays so we're not stepping on each other's feet? Like, where's this dance that we can kind of create together to kind of be patient-centered? And like, again, you're not always going to agree on everything. Like, there are certain things that like you have a background on that I just don't, and then I wouldn't be able to understand that just based off of background. But I would think that generally what typically happens is they see us first, kind of like a portal of entry. Mm-hmm. And then it goes into the more like Western I guess that's the best way to put it, but like less non-alternative care practices, medicines or whatever. Mm-hmm. CAMS, I don't know the name of it anymore. And then it goes into that kind of like route. But I don't think there's anything wrong with also being able to see a sports med doc to know that you have that route or a team behind you. Because like, for example, like I'm sure you have seen plenty of patients as an orthopedic surgeon where you're like, you're not a candidate for surgery. And then, but me, I'm like, you're not going to be a candidate for surgery, but go see the surgeon. They're going to tell you the exact same thing. Mm-hmm. And it's only until they heard it straight from your mouth where they finally get peace in that idea. And mm-hmm. they have to go all into rehab. Mm-hmm. Right. So it's this team where like, we're basically backing each other up, creating the same rhetoric, as long as it's a correct rhetoric, which I think is the biggest part that makes what we do all difficult, where it could come from any which way. Cause like someone might come to you first from a different sports med doc and you're like, I need better rehab. And the person you're seeing is trash. So like, you need to see this guy that I know works with this population, for example. Just as an example. And so it would come my way from an orthopedic surgeon, for example. So I don't know if portal of entry is the right word, but generally that's usually where it starts.
So one of the things that I've discussed, again, this has been primarily with the younger chiros that I've spoken with, is this idea of MSK triage, and which is basically what you just sort of, portal of entry. It's basically what you just talked about, and that, we would have, whether it be chiros or physios or a chirophysio team, whatever, do portal of entry, and they see people, they kind of triage them, and then they say, hey, you know what, this is purely mechanical, musculoskeletal, we can treat this, or no, you need to sort of go a little bit further up the chain, speak to the sports med, or no, you need to speak to the surgeon. And we in Ottawa at the present time, we have this model that is being tried right now, which is called the Isaac Spine. I can't remember exactly what the acronym stands for, but basically it's a MSK triage for spine problems, both neurologic and mechanical spine problems. And it's made up of chiros, physios, physiatrists, orthopedic surgeons, and neurosurgeons. And basically, they've come up with a standardized assessment protocol, and they've agreed upon a treatment, a standardized kind of treatment approach for non-surgical, non-neurologic mechanical problems. And then they've also established a direct entry path for people who have neurologic instability or anything like that. And so the Ontario government is this. So this is a pilot program. They're watching this because if it works, they want to roll it out to the entire province. And basically that's what it is. It's a triage, right? And so everybody, prior to starting it, the physios, chiros, and all the docs sat down and said, okay, well, here's what we think is important. Here's how we'd like people to be assessed. What do you guys see? What do you think is important? They hashed all of that out. And then they came upon an established protocol. And so that's what they all work through. And so even though everybody might have their own approach to treatment or their own approach to diagnosis, as a group, they've agreed that we're going to look for A, B, C, D when we're assessing the patients. And then based on the information that we obtain from that, we're going to then triage people appropriately to each division, right? And so I think that is the way that it should be. And I think that it effectively utilizes everybody's expertise. And then it also expedites the system because, as you mentioned, like I would say 50% of what I see is surgical. Okay. And the other 50%, they don't need me at all. And I send them off to a chiro, physio, or sports med, or whomever. I think that for me, my batting average is a little higher than average because I have 2 sports meds that work in my facility, right? And so all of my consults, I throw back to them so that they can triage out the non-operative stuff, and then the operative stuff comes to me. And when I have content that I've put out, say on YouTube, pertaining to chiropractic or whatever, people go, oh, you're a surgeon, all you want to do is operate and operate, and which is not true. Lots of what I see, as I said, 50% of what I see is non-operative, and I'm treating people with exercise and rehabilitation and other kind of modalities. But it's a bit of a double-edged sword because although I don't think every patient needs to have surgery, if the system worked the way that it should, right? And if you were looking to make the most of it took 17 years for me to become an orthopedic surgeon. So if you were looking to make the most of that investment, you would want every single patient that showed up on my doorstep to be a surgical patient, right? Like, of course. And you would want everybody non-surgical to have been triaged out to not waste my time, right? So I don't think that every patient needs surgery, but I'm a surgeon, and sure, like I like to operate. That's why I went into surgery. And ultimately, if you wanted it to be as efficient as possible, that's what you would want from me, right? Like you would want every non-surgical thing to be triaged out. You'd want only the surgical cases to show up at my door. They've been vetted by everybody else. I go, oh yeah, Raymond's right. You need surgery. Boom, we're booking it next week. Away we go. that's the way it should work, but
Yeah.
it doesn't really work that way.
Yeah, like you basically, by the time it reaches you, you've probably wanted to have exhausted all other opportunities beforehand. I
Exactly.
always tell it to patients, I'm like, even if you do need surgery later on, it's not going to hurt getting stronger prior to surgery.
Yes. Yes.
So
Right.
like we don't have to stop care while we're waiting for all of that. Like you could still get strong for what you have available. You just need to, we need to find out what that entails.
So let me ask you, as you were talking there, I was thinking about how your approach. Um, how do you think, if at all, your experience as an RN has influenced your approach to MSK care?
Oh, I'm one of the chiros that would be like, if I could tell someone to take some Advil for like just take some Advil, I would be happier. It's like if they took Advil some days, like this is me speaking as a nurse, if they took Advil and then we can get them to move better, then the next day they're sore, but they're sore from movement, I'm happy with that. But as a chiropractor, it's out of my scope of practice. So I
Yes.
can no longer do that. So it has been frustrating in that regard. I think there's definitely a time and place. And in school, they demonize NSAIDs. They're like, this is like, you could do it without it. I'm like, yeah, you can, but do you have to? Is the question. Like, is that always necessary? I'm sure it is, because like there's like a few papers that say that it speeds up healing if you don't have early intervention of NSAID use. But there's also like, there's a two-edged sword. Like if that gets them moving faster and less fear avoidant, then I'm all for it too. Like what's the point of that? So that's where I've had a hard time, because I think the Western medicine, I guess is the best way to put it, speaking from Kairos, is it's like I am totally on the favor of that side. So I've had plenty of arguments on Facebook with people who don't agree with me, and I've learned to just be like, have a good day. I'm not going to talk about this anymore.
There you go. Have you ever considered about maintaining both qualifications?
The only reason I didn't was because I was required to have a certain amount of hours during school. And then in order for me to do that, I would have to fly back to Calgary, make sure I have casual shifts set up. And like, there were only week breaks in between quarters. So like, it wasn't enough. And it would have been like $500, $600 a year. I'm like, I could probably just eat better throughout my chiro. It's like, instead of doing that. So yeah, no, I actually wanted to, it just wasn't, it wasn't a viable option.
Okay. All right. So let's get to a more touchy subject. What are your thoughts on the chiropractic concept of subluxation and manipulations? I always got to throw this in here to see where people's heads are at.
It's funny because when I read this, I was like, oh, this is going to be a fun one to talk about. Because like, if there's anything more, if anything creates a bigger dichotomy in the MSK realm, it is the chiropractic adjustment. I use them. I manipulate the cracky backy, as Aaron says, or whatever he calls it, the cracky backy. I use it. I think it is a great way to introduce movement, especially if they like it.
Yes.
You're just meeting patient expectations.
Yes.
I don't think it's a cure-all. I don't think I'm gonna heal gallbladder cancer with it. I don't think I'm gonna do any of that crazy stuff. I could count on one hand where, for whatever reason may be, the adjustment was the thing that got us over the hump.
Mm-hmm.
Like on one hand, out of all the patients that I see, I could count, and I couldn't even fill that hand. And I don't think it's what people think it is, but I do think if we talk on pain science, A, it's an introduction of force. B, it is a stimulation of mechanoreceptors that are in the joint space. Like that's all it is. So it gives a pain relieving aspect, and then we could just get them to move after. So I was just like, perfect, boom, that's all we need to do. And also like in chiro school, I was just like, if this is what I came here for, I'm going to be really good at it. So I may as well. and to be fair, one of the sports med docs that we worked with, he had said he has, chiropractors in their earlier years tend to just be better with like moving the body because they're more confident in it. And it's because we were forced to do it for years, like to just like put joints at their end range, feel what the joint is actually doing, like in terms of like, is this an impingement? Like, is there a bony end feel here? Or is it like, is there like a capsular movement here? Like, can I stretch this out anymore? But it's not what people think it is. It gets really sensationalized on TikTok. I have a ton of friends that do the whole microphone thing now too.
Yeah.
And I have so many friends that are just like, you should do it. It's amazing. I was like, that is not what I do. Like, I do it, but that's like 1% of what I do in my half an hour visit. Like, I have some patients I forget. And at the end, they're like, can you just like crack my back? And I was like, oh yes, of course. Like, let me see what I feel like you need to move a little bit more. Or like, I'll look at the history. If people tend to like arch their back a little more often, it's called like a lumbar extension stabilization strategy. I'll like put them into flexion and introduce a force there, but it's like, that's all it is. It's not, it's way more glorified than people think.
No, man, I love what you said, that it's a tool to introduce movement. And I think, because when people say to me, oh, you hate chiros, what do you think they're good for? And I say, to introduce movement. That's what I think that's their bread and butter, and that's something that they can help people in an acute setting who would not otherwise be able to move. I think that's perfect for them. And I was recounting, I spoke to Aaron yesterday, and I was recounting a story to him where about 2 weeks ago, so at our gym, we've never had maces. And just before the pandemic, we had Rick Brown from California come up and do maces for us. And so we don't have any yet, but I have some on order. And so recently I've been playing around at home because it hasn't come yet. And I thought, oh, how can I jerry rig a mace? Well, I had a 10-pound sledgehammer. So I've just been playing around, and I don't have any formal training, just a little bit of stuff from Rick, but that's it. So I'm swinging around this mace at home, and I'm introducing a lot of sort of rotational thoracic movements, lumbar movements, which I do some stuff there, but not quite to the same extent with this long lever pendulum, right? So I was doing that, then I was doing it for about 4 or 5 days. And then one day I decided, like I recently moved, and our new house has a pool. Never had a pool before. And so the pool was finally clean. It was a nice day. And I thought I'm gonna do some intervals of treading water. I can swim. I have my advanced open water diving license, but I can't really tread water very well. I'm very, like, I don't have that high body fat percentage, so I sink like a stone, right?
Dense tissue.
Dense. So I thought, hey, I'm gonna try this, and the combination of me doing 4 or 5 days of rotational stuff, and then treading water intervals for half an hour. I kind of was doing that, and that when I was done, I just kind of got out of the pool, and 2 seconds after I got out of the pool, I felt something weird in my back. It didn't hurt. It just kind of felt strange. And then I walked from the pool to the back of my house, which is about 60 feet. And by the time I got to the back of my house, I had to crawl through the door. And then I laid on the floor in my house for about 5 hours. And my daughter, because she knows what I do on stuff I've done on YouTube, and she's actually been to a chiropractor a few times. And she says, I bet you want a chiropractor now, right? and I was kind of, and I was thinking, I'm trying to do some McKenzie movements, trying to just get myself moving. But deep down inside, I'm thinking, it wouldn't necessarily be that bad to have somebody just move me right now. And yeah. I knew at the end, once I got moving, the spasm would settle and I'd be okay, right? And it took 5 hours, but in those circumstances, man, someone who can get you to move, it would be awesome. And I think, and what the thing that Aaron said to me yesterday, he said, think about this for a second. This is you as an orthopedic surgeon who has an interest in rehab and movement. You know the natural history of this problem. You know that, and even still, you were kind of like going, oh my God. Like, so imagine somebody who has none of this education and what they're thinking, like, I'm gonna die, I'm broken, like, what's going on, right? So I think that, yeah, that's a perfect situation for Kairos, right? To introduce movement.
I also think because of that, it's like some people would take that as an opportunity, a very good business opportunity, to sell you 3 visits a week for the next 12 weeks.
Of course.
Because it's a great sales pitch. It's awesome. You get someone in a time of need. It's like that Wolf of Wall Street, like, sell me this pen kind of thing. Like, that's the perfect time to, like, their motivation for learning at that point is really high. Yeah. But at the same time, it's like, yeah, like just calming them down. You add the movement. It doesn't hurt nearly as much. You're like, oh, this is a safe range of motion that I can actually access. So then the muscles calm down because there's not that protective effect. And that just, whether or not it speeds up the situation, I think there is movement confidence that happens.
Yes.
And then quality of life happens. Like that improves. Like that's what makes it accessible. And I think that is a misunderstood thing in chiropractic is like, we're not healing things. You can't prevent injury. It's almost impossible. Like there's 2 things that prevent injury. It's like, well, if you've already had a previous history of injury, you're already at higher risk for injury. So it's just kind of like, okay, cool. But you have to give them the confidence to go back to regular life, because fear avoidance is like a nail in the coffin. You won't get better if you're afraid to move. You don't get better at something you don't do.
Yes, exactly.
It's just like, that doesn't make any sense.
Yeah. So. Yeah. Okay. So let's switch gears, man. And I have to say, I'm really enjoying this conversation with you.
Me too.
Despite what everybody says, I don't hate all Kairos. So, so you obviously you have an affiliation and enjoyment of Olympic lifting, and you've been involved with CrossFit. You also mentioned your previous history as a dancer, break dancer, hip hop dancer. So how do these activities interact or intersect with your profession as a chiropractor, and how do you think they influence your approach to what you do with patients?
This one's pretty interesting because it's a great question actually, because I think a big part of what I've kind of come up to till recently has been a part of that, because like dancing, I don't know if it has a huge influence, other than I think if someone enjoys it, they're willing to do more. Like you will tolerate more of what you love doing.
Mm-hmm. Mm-hmm.
You know what I mean? So like if I give a runner rehab exercises that are like just lifting, they will hate it and they will be less likely to actually do it. So the same thing goes for dancing, is like they're strange movements. Not everyone's introduced to them, but because these movements haven't been in an opportunity to be demonized, like you can roll your spine, you can move these things. It's in that environment. They're no longer thinking, oh, this is a dangerous position, because it's dancing, right? So, but I don't know if I've ever given that a careful thought until that question. But with weightlifting and CrossFit, it's like, it's really taught me that it's a volume thing. It's how often are you doing it? What load are you doing it? What intensity are you doing it? And then the next question is, did you give your body a chance? Are you sleeping enough? Are you giving it the right amount of nutrition to facilitate the changes that need to be happening? Because weightlifting is very hard. In later years, I'm not a good weightlifter by any means. I am forever intermediate, if that. I think I'm like patting myself on the back for that one. it's grueling, but it's also a reminder that, like, for example, I had a shoulder injury and I was having a hard time snatching. You don't always have to full snatch. You could go power snatch. You could do a muscle snatch. The same thing goes for someone who likes gardening, because I think Aaron used that as an example. In everyday life, if that's what you love to do, and you want to garden on the ground, and you're not able to do that, you have to figure out a way to get them down there quicker, and you just make it accessible, like immediately. You could change the range, you could change those kinds of things, and change the load. And I think if you take that idea to all movement, is you have to monitor your introduction to that movement and like how often you're doing it, or like, and then get them as close to that as quickly as possible in a pain-free state, and then continue to layer those things on.
Okay. Do you think that your experience in strength training, CrossFit, and breakdance have changed your thoughts about musculoskeletal care?
Yeah, absolutely. I think it's hard for me to delineate the two from each other because I was doing it while I was in it.
Mm-hmm.
But I think a strong body is able to tolerate way more.
Mm-hmm.
Like I think is Adam Meekins. He says there's nothing wrong getting strong. Can't go wrong getting strong. That's what it was.
Yep.
And it's like, yeah, like let's just speak on the knee. A patellar tendon that could tolerate more force is less likely to get tendonitis comparative to a patellar tendon that's never been loaded in that position at all. So it's just, you come back down to the basic elementary sciences of physics and material science, if you look at that. And I think knowing that like weightlifting requires a lot of mobility and a lot of strength, very terrible cardiovascular exercise. Never ask me to walk upstairs unless you want me to breathe heavy. But my body can tolerate ranges of motion and a large amounts of force in those because I use it often. And I tell my patients that same thing is, if you introduce these things more often, like picking up a child off the ground is going to be much easier if you could pick up 150 pounds in a barbell form. You've basically taken out all those like uncertain variables and then prepared their tissue for a large amount of load, so that when they are into a scenario to which you can't control the variables, at least the tissue is able to tolerate it because you've done it into a setting where you've developed that. I think everyone should be strength training in some form or regard. Well, I think it's silly not to.
There you go. So I was going to ask you, who do you think should be strength training? But that you already answered that question, and I agree. Everybody should be lifting all the time. But one thing I will touch on about cardio, although it's lifting is not necessarily a cardio aspect or cardio exercise. I had a conversation with Matt Wenning, who's Olympic or not Olympic, but world champion powerlifter. Yeah. And the one thing he said to me is that strength training has a kind of sneaky backdoor cardiovascular effect, in that he said the stronger you are, like if you are not as strong, you are going to be working harder to lift a particular weight than will somebody else who is stronger, right? So as you said, like if I could snatch 200 pounds or 250 pounds, right? And then I got to lift something over my head. If I'm lifting 80 pounds over my head, the person who can only lift 100 pounds over their head is going to be working way harder than the person who could do 250, because they're going to look at that 80 pounds and laugh, right? Boom. Okay, there it is. Whereas the other person's going to be struggling. So he said that strength gives you the ability to add in volume, right? Because it's like, well, that weight is so much lower than what I normally do, that I can now continue to work. Whereas the other person, they can't do the volume because it's too close to what their maximum is, right?
Absolutely. I also tell runners that all the time. I'm like, running is upwards of 3 to 6 times your body weight per stride. If you can't tolerate that type of weight, you're going to put yourself at risk for tissue injury just simply because your tissue can't tolerate it. You're
Mhm.
using more effort when you could move weight and then use less effort. It should increase your running economy with tendon stiffness or whatever the case may be. There's many routes to that, but yeah, totally agree with what you're saying.
Not to mention for runners that when you look at strength, right? Stride length is a function of your anatomy and the length of your levers, but it is also a function of your push off power, right? And so if you are stronger, right, and you are able to, with each individual stride, cover more distance, then with the same cadence, you wouldn't have to do anything. You don't have to increase your cadence. You could run with the same cadence and be faster, right?
Absolutely.
It's
Yeah.
just by being stronger. And it's like when they're, oh my God, I did my 5K and I did it in 10 minutes, like, or whatever it is, 20 minutes. Like, come on. Like, they all want to be faster. All you got to do is pick up some weights and lift some weights, and you could be faster,
Yeah,
right?
introduce it that way.
Yeah. So what aspects of musculoskeletal care do you think the chiropractic care is appropriate for?
It's like some of the research is apparently really, really good for low back and neck. I would like to think, because we don't really, actually, I guess we do, but it's almost always a hip issue. I think it depends on I'm trying to do this. I'm trying to skirt around it.
Are you trying to be political?
Not for you guys, not for your sake, because I do have friends that practice differently than I do. And I want to say this without saying that they're not doing the right thing. I just think I'm more right. No, I think it's like, I'm just going to use a quote, and this pissed off a lot of people in the intern room when we were in chiropractic school. A colleague of mine, he goes, "We're basically just personal trainers that can diagnose," and no one liked that idea. And I was just like, that's actually very true. Like, that's pretty much what we do. If we're not guiding them through exercise, we are putting them using our bodies through exercise, like loading the joints or whatever the case may be, whether it's passive or active. But that's essentially what we are. Like, we facilitate a process where we're able to identify red or yellow flags and probably have a little bit more confidence to be able to give patients confidence that they're doing the right thing. But we just facilitate their movement practice, I guess is probably the best way to put it.
So it's interesting that you used that quote. I've never heard that quote before, but I like that. And one of the things that I've talked about with Aaron and some of the other chiros that I spoke to, but also I've spoke about this with some of my colleagues, sports meds and physios as well. I think that my own personal opinion is that everybody who's in musculoskeletal care, whether they are physician, therapist, whatever, I think that we all should have our CSCS or ACSM or some equivalent. We should all be certified trainers, because I don't think that you can truly have an understanding of musculoskeletal problems and what is required to fix them without having an understanding of how to train people. Because I think that rehabilitation, training, elite performance training, it's all the same shit. It's all the same. It's all the same shit. All that we've done is the difference between one group and the next is where you are starting on the training spectrum. That's it, right? So if you're injured and we're rehabbing you, we are regressing everything down to a level where you can do it. And if you are elite, performing at the highest level, we are figuring out ways to progress and like make it harder, right? To meet the level of performance that you are at. But we're still using the same, like we're all using periodization techniques. We're all like, it's all the same. It's all the same, right? The exercises will be a little bit different. The volume, the intensity, frequency, a little bit different, but it's all the same. And so I, I I'm a little bit, as you can tell, I'm a little bit outspoken about things.
Yeah.
My colleagues think I'm crazy, but I think, listen, man, I let me bash my own profession here a little bit. There are lots of very qualified orthopedic surgeons, lots of very qualified physiatrists and sports med physicians that are very smart people. They have a lot of book knowledge, okay? A lot of understanding of the medical problems, and they have a great understanding of the literature. But it's like, man, if you ain't a gym rat, if you haven't spent time in a gym, and if you don't understand how it works to build muscle and what it's like to feel delayed onset muscle soreness and all these kinds of things, I just think there's a part of your knowledge base which is missing, right? And there are lots of times when I get referrals from my colleagues, and I look at the referral and I just, the first thought that comes to my head is like, you've never picked up a barbell, have you? Right? Like, and the consult has nothing to do with that. But when I see what they're referring the patient for and the question that they're asking, I'm thinking, like, if you just understood training a little bit, you would know the answer to this, right? You wouldn't need to send them along to a surgeon. So I just think it's important. This is a new idea in terms of medical specialists, but I think that we need to have that. And it's not just us. I think chiros, physios, all of them. I see, again, I employ physiotherapists in my facilities. We don't have any chiros, although we have spoken to a few, but I employ physiotherapists. And sometimes some of the questions that they ask, I'm like, and everybody in our facility, I always tell them, you need to walk the walk, talk the talk. So we all train and we all lift and we all do stuff. But sometimes I think you need to have a view, the perspective of a trainer for this question that you're asking. You need to think about this from the viewpoint of a trainer. And I think, at least for myself, I think that I've been blessed in that I was a high level competitive athlete. I was then also a fitness instructor and personal trainer for 15 years. And then I became an orthopedic surgeon. And so I kind of look at it from with a number of different hats. And I think that's part of it, you know?
I totally agree. I don't have my CSTS. I've been like really lucky to have, CrossFit was different. Like when I fell into CrossFit, like you can get a certification, and then I happened to learn under some really brilliant trainers. They like trained under Charles Poliquin and stuff like that. So like, I'm really lucky that I was just exposed to those things. Because I don't think unless you're looking for it, you're not going to get it. Like I was just lucky. I just happened to meet mentors that were very, very intelligent about this stuff. So like, I think I totally agree. I think it would be a very valuable asset to know this thing. It's hard for me to say that it should be mandatory, mostly because maybe you know what, you're right. Okay, I'm not even going to try to like make people upset anymore. It should be mandatory. Like you should be able to know how to make like an easy training program for someone from 80 years old to an elite level athlete, or at least be able to look at what they're doing, like their program, and be like, this is where you're actually overloading it, or this is where you need to add a little bit more of this stuff, or like just be able to look at it and not make it look like it's a completely different language, because that's it. It's just because then you're just saying one thing and then they're saying another thing, and when really there's like this perfect middle ground that you're just not able to go because you're not even dipping into their lifestyle, right? So
you know, it one thing that it kind of drives me nuts is when patients show me, they say, hey, this is what I got from my therapist, and they show me a sheet. Here are the exercises. And I'm like, Okay. So that's what you started with. Where's the progression? How's that change? Oh, well, I do this every day. I do this 3 times a day, and I've been doing it for 3 weeks. And I'm like,
Oh man.
like that drives me nuts. And a therapist who doesn't understand that you have to progress things, that drives me nuts. I'll touch base with you again, and we'll carry on the conversation. But I guess that's it. So as always, that's been a word from Dr. Chris, and today, Raymond St. Augustine. Thank you very much for joining us, and we'll chat next time.
Have a good one.
All right. Thanks.
Bye.